Nora Stern is a physical therapist and clinical program manager for comprehensive pain service at Providence. I first became aware of Nora's work because my primary care physician at Providence, I saw a pain toolkit poster in the office, and I said, "Hey, what's that?" And he showed me, and it was a lot of the similar information that I'd been learning from people like David Butler and Lorimer Moseley, and some of the resources that Whitney discovered. So since then I've realized that I should probably speak to Nora more and we should communicate, because she's a wonderful wealth of knowledge with regards to how to implement pain education in the context of working with somebody who's experiencing pain. I'm glad the Oregon State Pain Commission is using providers like Nora. We need to bring this information to the public, to healthcare providers, because it's incredibly useful. So, Nora, is there anything else you want to include or
I
tell
can
the
just
audience?
talk about it.
All right, good.
Yeah.
Nora Stern, everybody.
Thank you. Thank you, Tim.
One more thing. This microphone is going to be over here if you want to ask a question, because we're having problems hearing the questions. So I'm going to put this here.
Yeah, and I'll also repeat questions. So, and if you have a question while I'm talking, I'll try to answer it as well. If it seems like it's going to make it difficult to move things along, I'll ask to wait to the end. So thank you very much, and I'm glad to be here. Yeah, so I work primarily in pain education and come out of a background of rehab services. I've worked with complex pain patients my entire career, and worked with pain education kind of since the inception of the work internationally, and have kind of come out of the training that David Butler and Lorimer Moseley first began with this amazing resource, Explain Pain, which is what kind of started the pain education revolution. If you've not read this book or read Explain Pain Supercharged or watched one of David Butler or Lorimer Moseley's YouTube or TED Talks, you should do it, because they're geniuses. So I bow down to them. And I'm fortunate that I serve on the Oregon State Pain Commission, and that has allowed me to kind of combine the work that I've been able to do with Providence with some work at the state level that spreads the content even further. And I'll show you some of the resources that Providence has made available to the public domain, which has allowed that collaboration to happen. So I'm going to talk with you about some of the things that are happening around the state, around changing the conversation about pain, and then talk a little bit further about what changing the conversation about pain means and looks like. And I think you got a little bit of a background on the new understanding of pain, the idea that pain is biopsychosocial and an output of the brain and the nervous system. And that is an incredible game changer, right? It's an incredible game changer in helping promote more of a sense of safety and hope for patients who live with pain. And it's a challenge for us, especially those of us who do manual therapy, to reframe our thinking about the skills that we're using when we put our hands on somebody, and whether we should be putting our hands on somebody, and what message that's giving. So we'll talk about that a little bit more. So first of all, we ran into some problems with this a moment ago. I'm gonna need some help here, doo-dah, doo-dah. I'm going to let you fiddle with that. So first of all, the state, huge opioid crisis. Every state is doing a great deal to tackle the opioid crisis. Oregon is head and shoulders ahead of the curve in terms of doing really meaningful things to affect change for people who struggle with pain. So there's something called the Oregon Opioid Initiative, and its main goals are to change the tendency to prescribe pills by improving non-pharmacological care for pain, which means in large part those of us who work with the body, but hopefully who begin to connect the body and the mind and help people reframe their understanding of pain, as well as decreasing the circulation of pills in the system and promoting a reduction in overdose deaths as well as non-fatal overdoses by improving medication-assisted treatment. So those are the three main pillars of the Oregon Opioid Initiative. And there's a state conference that's going to be happening next month, and when this comes back together, I will show you the flyer for that. It's being put on through an organization called Lines for Life and the Oregon Pain Guidance Group, and has been happening down in Ashland for about 7 years, and they have been fantastic leaders in the opioid work and over, there we go, there's a poster. So this is is it working now?
Yeah, be careful about any other button.
Don't touch any other button. Okay. So this conference is happening in May in Eugene, and it's now a statewide conference. So it had been regional in Ashland, and those people down in Medford, I tell you what, Jackson County at one point, by my calculation, had the highest incidence of prescription opioid usage on the planet, because Jackson County had the highest in Oregon, and at one point, by some configurations, Oregon had the highest in the nation, and we have always had the highest in the world. So they have been doing heroic work, and so now we get to bring the conversation together as a state and talk about opioids, pain, and addiction together. So it's an exciting time. There is a lot of talk about opioids, but the emphasis is beginning to move towards non-pharmacological treatments, and this is the Oregon Opioid Initiative. So it's important for those of us who do those non-pharmacological treatments to be at the table to answer people's questions, right? To hear what's going on too, and to hear the struggles that your patients have, because some of our, a lot of our patients more and more have, I mean, how many people know that they have clients who have, are using opioids? A lot, yeah, a majority of people. How many people think that your patients may have a substance use disorder? Some of them, yeah, so that we're dealing with that. It's a crisis everywhere. We need to understand what's going on. So this is a good way to kind of get a heads up. Things are not as pretty as they seem. And then this is something that's happening within the Tri-County region that I have the pleasure of participating in as well, the Tri-County Opioid and Pain Safety Coalition. And it has 8 pillars to it, and the 2 that are kind of germane to this conversation are that there's a subcommittee on improving best practice pain care and access to it, which has meant bringing some of the payers into the conversation, and I'll show you one of the places where we've had the most success. And then clinician and patient education, and those are the 2 areas that I've been focusing on mainly. The coordinated care organizations are the way that we divided up the state to cover our Medicaid populations. So as you know, when states were given the option of accepting expanded Medicaid dollars and managing them within our own state, some of the states said yes and some of the states said no. We said yes. And we at that time had a governor who was a physician and really smart, and Kit Sauber said, you know what, you can't opt out of this. Every large healthcare organization has to take a piece of the pie. Every payer has to take a piece of the pie. And so the whole state is covered. You'll see that whole east side of the state is one CCO, which is pretty amazing. And very sparsely populated, but also very sparsely served by clinicians. So the CCOs have the ability to, they are given a fixed monthly amount. So it's called a fully at-risk service. So they're completely at risk for that patient population. But that means that they can make their own choices about what they do with their dollars. And some of the CCOs have done some really creative things, including using massage therapists, yoga instructors, giving people gym memberships. And there's an opportunity for creative innovators, especially in sparsely populated areas, where a massage therapist may be one of the resources that will help patients to say, I've got a great idea. Is there a mental health person we can work with? There's movement groups that are happening, meditation and movement groups that are happening around the state that are covered by the CCO. So there's kind of some scrappy innovation that's happening that's very creative. And these are areas where people don't have other services. So it's been really interesting to watch and fun to work with. So this is another thing that has helped that process happen, is that there's a policy change that occurred in the Oregon Health Plan around back pain. Anybody aware of the improved back pain coverage? So the Health Evidence Review Commission, which I had the pleasure to serve on as well, here's one of the reasons we have an opioid crisis. There's a bunch, right? It's been a trifecta of horribleness that happened 15 years ago, and that's a whole other lecture. But One of the things that happened was that the Joint Commission on Hospital Organizations required that all clinicians ask about pain at every visit 20 years ago. Pain became the fifth vital sign, right? And so a physician says, how's your pain? It's terrible. Now you have to do something about it. What can I do about it? Medicaid patients, they had nothing to offer them besides opioids. And then if that didn't work, they could come to the emergency room because you can never deny somebody access to the emergency room. That's one of the big reasons this started. So, because we accepted federal dollars for Medicaid, we were incentivized to do a better job of treating pain. So the Health Evidence Review Commission looked at that and said, this is stupid. We have people coming into the emergency department, getting surgery, getting opioids, getting epidural steroid injections, and there's no evidence for that. And the reason they're doing it is because they don't have other coverage for anything else. So we were able to look at the evidence and improve and increase coverage for cognitive behavioral therapy, chiropractic and osteopathic manipulation, acupuncture, PT/OT, non-opioid medications, and then where available, and this is where especially the remote areas comes in as an opportunity, yoga, interdisciplinary rehab, supervised exercise, and massage therapy. And the Health Evidence Review Commission is meeting again right now to look at expanding that. It's all got to do with economics. It's where the rubber meets the road. So if they realize they're hemorrhaging money, we are responsible for it. The state of Oregon, we've got some incentive to do something about it, and we've got creative, open-minded, aware clinicians who are willing to say, you know, there's not only are there lots of ways to skin the cat, but we all have to be working on it together. It does take a village to treat complex pain. And I got to tell you, you know, this is one really important message to get about pain. None of us can do it alone. Right? So if you're working with a person and they have a lot of challenging pain going on and you're really confused and disoriented about what to do, one of the things to do is to think about who else should be involved. Right? And this helps with that. So I'm very proud of our state for that. It's really exciting. Pain care is everyone's job. If we have more ability to treat patients, as Jack Kennedy said, with great privilege comes great responsibility. We have to do a better job. For my profession, last year, the Physical Therapy Association came up with a tagline, choose PT first over opioids, national campaign. I about had a heart attack. I mean, that's great for acute pain, that's great. If we're saying that about complex pain, people, we better get better at doing that. And I gotta say, my profession has stepped up. We are doing an awesome job of changing the conversation about pain within physical therapy now. It took a while, but we are doing a great job. So I think that's what all the professions really have to do. We have to do a better job of shifting our thinking from the old model of thinking that pain comes from the body and changing the way we think, the way we create treatment plans, and the way we reinforce messaging to our patients. Because what they believe is going to affect what they buy into and what they actually do, right? Because
what insurance pays for is going to make a big difference too, like you said earlier.
That's true. That's true. Payment, so what the comment was, what insurance pays for will have a big influence. It absolutely will. And I will also tell you, though, that if you have lots, so that one of the things I worry about all of that coverage, 30 visits of PT/OT, chiropractic, and acupuncture. What if somebody goes to a physical therapist, a chiropractor, or an acupuncture, one practitioner who thinks they're the hero, pain resides in the body, and I'm going to chase that pain all over the place because I'm the one that's got to fix this person. That's a disaster. It's a disaster economically, and it's a disaster for the patient because they just learned that there's an external locus of control in their patient, and they have to have somebody else fix them. And that one person is the hero, and damn the CCO for not allowing them to have more coverage. So yes, coverage is important, and there's a responsibility on us to use it properly. Big time. Does that make sense? Yep. Yeah. So I'm on the Oregon State Pain Commission. There's a required module, and this was kind of, I think, why Mark asked me to come here. A required pain education module for a lot of licensees in the state, not massage therapists at this time. Actually, if you're one of about 17 clinical groups, you're required to take 7 pain-related continuing education hours within the first, I think it's 2 years of license. One of them has to be our online module. We just did a new edition of it, and it just got released, put a boatload of work into it, and it's getting some rave reviews. It's really been fantastic to be able to use this not only to help new incoming clinicians use a common language, but it's being spread among large healthcare organizations. My organization, Providence, is spreading it among hospitalists, pharmacists, primary care docs, rehab services. Kaiser's spreading it. And actually, and I think this is a tremendous compliment, one of my colleagues said that she prescribes it to her patients. So I thought, whoa, we hit it. If we wanted to make it health literate for patients so that clinicians don't have to translate in their minds, do I use smarty pants language or do I use understandable language? We just used mostly pretty plain language. And so I thought that's pretty good success. So this is available. It's free. And I can forward the link. I have it on one of the other slides. But you can also just go to Oregon State Pain Commission pain module and pull it up. It's a 1-hour CEU. So basically what it talks about is the idea that we're moving, as was just talked about, from the old model, the idea that pain resides in the body, that pain is directly associated with tissue damage and with bodily harm. We're moving away from that. Why? Because it doesn't adequately explain a person's pain experience. We would say, based on the old model, that if you have that X-ray on the right, which shows very significant degeneration, bone on bone, right, that you're going to have severe pain, right? But research shows, and it varies depending on which studies you look at, anywhere from 8 to 85% of people, depending on your age group, with pretty significant findings on MRIs and X-rays are actually asymptomatic. So if that's the case, we should be careful about how strongly we message the meaning behind X-ray findings and when we promote them as well. Because again, people will then get the message that they're damaged, right? So if the pain comes from the body, how does that explain people not having a lot of pain when their X-rays look like that? How does it explain people who have phantom limb pain? They have pain in the body part that's not even there. Right? Fibromyalgia, pain all over the body, pain that moves around, but they didn't get injured in all those places. Is that a raising the hand, or are you just exercising?
I see the extremes happening, just like with all the knowledge or knowledge that comes up, that it's one way or the other. And so that's where I'm getting a little cognitive dissonance myself, because sometimes the people will not be in pain, and now we're saying, well, this is a good thing, but that joint may fail, and they'll go, oh, I don't know what happened, because that is an underlying problem and patterns over time. So I have a little bit of that, just because I've always said absence of pain is not always wellness.
Okay, so the comment was absence of pain is not always wellness. Yeah, that's a pretty complex question or comment. Pain is a warning, always. Pain is a protective mechanism designed to give us information. The question is, what is it giving us information about? Sometimes it's giving us information, hey, there's something going on down here you'd better pay attention to in this body part. Which body part is that? And then the brain has to make sense out of all that. Sometimes the information is, my tissues are ischemic because I've been lying on the sofa afraid to move for 15 years. Sometimes it's, I feel threat everywhere because I have a trauma history and my world is a scary one. So it's a complex issue. It is not simple, and I'm not saying ignore pain. What I'm saying is don't assume that the pain is only a result of tissue damage in the body part, and even if there is tissue damage in the body part, pain is always input, processing, and output. Okay, so there's always more to it, right? So that's the point, is that you want to be careful. If you have somebody who has pain that gets, persists, that's 17 out of 10, big black body diagrams, right? Pain that moves around, then there's more to it. And as a massage therapist, this is a challenge for you to think about. I think it's probably, this may be the beginning of some very robust discussions about what the best way is to think about using your services, and when to say, I now recognize that this is a place where somebody else needs to be involved too. Because there always needs to be somebody else involved when there's complex pain. It should never be one clinician, no matter how good you are, no matter how much your hands are magic. Any of us, me too. I'm a manual therapist. And I'm so relieved that I'm about to start working in a clinic that has psychological therapy in it. So we now understand that when pain looks like the one on the left and it's kind of moving around and gets worse with stress, that it's more a result of the assessment of threat. So what we know now is that pain is an unpleasant emotional and sensory experience that's a result of real or perceived threat. So our whole system responds to threat. It could be threat from an injury. It could be threat from fear of injury. It could be threat from fear of loss of work. It could be threat from loneliness. So some key points. Pain is a multidimensional experience. Pain is an output of the brain and the nervous system all the time for everyone, which means that all pain is real pain. So this new way of understanding pain tells us that we used to there was an automatic kind of judging of people. If pain resided in the body and you couldn't really explain it, then that person was a little crazy, right? Now we know all pain comes from the brain. So unfortunately, it's very easy for people to hear this until it becomes more a part of the common lexicon that you're saying that it's all in their head. And everybody will have that happen at some point. And I think that's where it's good for people to hear it in multiple ways. But in fact, pain is always a result of output from the brain all the time. Pain is in everybody's head, actually, but it's no more or less in the person's head if they have pain that has no obvious tissue-related etiology. Because, and this is the work of Lorimer Moseley, by the way, I credit him and Butler for all of this. Nociception, input from the danger fibers in the body, is neither necessary nor sufficient for pain. So what that means is I no longer call nociceptive fibers pain fibers. We no longer refer to nociceptive pathways as pain pathways in the body, or pain messages or pain generators. That is bad messaging. That implies that pain resides in the body. So information from the body is very useful and important, but it's one piece of the puzzle. It says, hey, there's something going on down here you might want to pay attention to. But it doesn't even tell your brain where it is. The brain and the sensory cortex has to even identify where in the body that sensation is occurring and then identify the meaning of it and the association and significance of it. So pain and harm are not the same thing. You can have pain without harm, and you can have harm without pain. And did Whitney talk about that concept yet? A little bit. So pain without, did we talk about some examples of where you could have pain without harm and harm without pain? Yeah, okay. So pain without harm, great. And this is great to remember because you can talk about it with people. Pain without harm, what's an example of having pain without harm?
Well, you're saying that doesn't exist. Because there's something in the brain that...
Oh, no, well, no, that's not what I'm saying at all. What's an example of when you could have pain without harm? Ice cream headache. That's a good one. It is a good one. Fibromyalgia is a great one, right? You have pain all over the body, pain that moves all over the body. You didn't have tissue damage in all those places. Now, some of the things going on may be some things that have changed in the immune system and things happening at hormonal levels, but you don't have tissue damage happening in all those places. It is not appropriate to chase that pain around as a massage therapist and try to work the pain out of the tissues, right? Because it's not coming from the tissues. Now, manual therapy may be helping them for some reason, but it's not because you're healing the pain in the body part. You're doing something else. You're helping the immune system become more resilient. You're helping calm the autonomic nervous system. You're doing good things, and it's good to label those. It's also good to help people not recognize that they are not damaged in those places. Yeah, yeah.
But isn't that the tricky part of the conversation and the work with like client-centered communication is because they're feeling it, And again, so many people have told them that it's in their head. If they feel like it's coming from their shoulder, if you don't pay attention to that, then they're always going to feel like it's there. Does that make sense? Same like,
So-
like depression.
Yeah, so the question is if they feel the pain in the shoulder, if you don't pay attention to their shoulder, is that maybe feeling dismissive? Yeah, that's a complicated question and certainly a valid thing to think about. And that has to do with maybe, yeah, there's a dance there. And I think it would take a long time for me to kind of do justice to that question about how I would answer that. It comes up all the time. But I think being able to say, but that's a good question, like, you have pain in your shoulder, and it gets much worse with stress. And it has been going on for 5 years, even though you've done things that it would make sense would have helped you, and it hasn't. And I'm curious about that, because we know that now that pain is related to a lot of different things, a lot of different pieces of the puzzle. So there's actually a video you could have a patient watch. I'm gonna pause on this because I'm actually realized I'm way behind here. So some questions you might ask that maybe would come up in massage therapy are like, I hurt everywhere. I need to rest as much as possible. I know it's not safe for me to move. You're the only person who can help me, right? So those are potentially threat-producing questions. And if you give an answer that gives people the message that pain is out of their control, their own personal internal locus of control, that their pain entirely resides in their body, and that you should avoid moving because the pain is harmful, you could be reinforcing some really bad thinking, right? So pain education itself is a treatment intervention. There's great evidence behind that. Oh, you want to take a picture of that? There you go. And this is an example of how you could kind of reframe the conversation. If somebody says, you know, my x-rays look terrible, I'll always have real pain. Rather than talking and focusing on the severity of the degeneration, we can emphasize the fact that degeneration is a normal part of age-related change. It may be a part of what's contributing to their pain picture. It may be part of it. It may not be, but there's a lot of things that we can do to change their overall wellness and resilience that they have the ability to have an impact upon. Whereas you can't have as much of an impact, say, for a knee replacement on the joint surfaces. So let's do everything that we can to make your system as resilient as possible now. Another example might be, I need to rest as much as possible. It's not safe for me to move. And physical therapy has been really bad at this for a long time, right? To say, oh, well, that exercise was painful, you better not do that one. It hurts to bend over and empty the dishwasher, have your husband do it. Someone comes into the physician or maybe massage therapy and says, physical therapy made me worse. Oh, well, maybe that's not a good thing for you to do. And then we're reinforcing the idea that that was dangerous. Whereas in fact, maybe they're severely deconditioned and maybe they pushed a little too hard at the outset, but they didn't harm themselves. Very rarely does exercise cause damage, right? So what we might say is, you know, it looks like there's been a really good workup done. And so now that we are confident that nothing harmful is occurring, as you get back to general activity, I know you're going to be uncomfortable, and I appreciate that you're painful, but I can tell you that you're sore but safe. That's a very positive, hopeful, autonomic nervous system calming message to give that encourages people to slowly return to activity. So this is an example of someone, a study that was done of a woman who said that she couldn't move past 10 degrees because she was painful. And then after going through a pain education class, and we use this in our pain education classes, she bent down to 70 degrees and she bent backwards as well. And the reason she was able to do that was because then when she got to 10 degrees, she said, oh, wait a minute, I'm sore but safe. So all those brain functions, weight shifting over the feet, inner ear sloshing, memory, sensory cortical representation, all became associated with maybe curiosity, a willingness to experiment because she recognized that that was not as threatening as it had been before. So I'll just go through a couple more things so you can see some of the resources that are available, and then if we want to spend a little time on the languaging, we can, otherwise we can switch to the panel. So this is a toolkit that is now available to the public domain of the Providence educational resources that we have that include videos and teaching aids and written materials, so your patients can go there and watch pain education videos that talk about how pain works. And these are this is one of the toolkits. It's, you can print them out if you want to. It's on the clinician side. And they have scripting on the back so you can cheat, remember what you're supposed to say. This one talks about a slow, gradual return to activity. There's scripting on the back and evidence. And there's one that explains the X-ray findings. So it's a way of kind of making the conversation easier. And what we do often is we'll ask somebody to watch the video, which, like the Understanding Pain video, which in 8 minutes kind of gives a simple overview of how pain is a multifaceted experience. And then we'll also have people go to the pain education classes. And then this is the module. And, so I just want, can I do a little bit of scripting with them? Is that okay? Okay. I picked out some things that I thought might be classic things that you might hear as massage therapists hear your patients say or ask you about. Patient says, I hurt everywhere. Patient says, I need to rest as much as possible. I know it's not safe for me to move. Patient says, you're the only person who can help me. So I'd like to ask, for the top one, I hurt everywhere. What's some inaccurate or what's some potentially inaccurate thinking that could be behind that, and some potentially threatening language that a clinician might respond with that could reinforce the idea that the person is damaged and that their fate is sealed in chronic pain that can't change? Let me ask it a different way. What's a potentially dangerous way that a person might respond to that? Not anybody in this room and not me. I never said anything bad in response to this question. Yes, we all have, right? We all have old thinking because we all came out of the Descartesian model. Everyone, right? So I hurt everywhere.
That's intense.
Huh?
That's intense.
That's intense. What are some other things that could potentially reinforce a sense of helplessness?
What did you do?
What did you do? Okay.
I can see that your foot is pronated, and that's what's making your knee hurt, and also your hip, and your back is very misaligned, and it's going to take a long time to get this in the right place.
Did everybody hear that? Yeah. That was great. And like, that's not to say that kind of biomechanical kinetic chain assessment isn't useful. It can be. But did you just hear how threatening that can be without the rest of the context? Yeah.
It seems like just full-on denial may also entrench them more. You can't possibly hurt everywhere.
You can't possibly hurt everywhere. Ooh. What did that do? It creates a resistance, first of all. Yeah, right. It's dismissive. Yeah.
Even just saying simply from a doctor's perspective, as I've been told, oh, you've had this for your whole life, it will never go away.
You've had this your whole life, it will never go away. Yeah. And I think that the risk for people who do, so that was the old message, right? Chronic pain will not go away. The best you can do is cope with it. So that was the gate control theory, and the best we can do is stuff it a little bit from the top. But with neuroplasticity, we understand we can do so much better than that. And I would never say your pain can go away completely. I just don't think that's helpful. But I wouldn't say the opposite. I wouldn't say I know how far I don't know how far you can get. This is a journey. We're just starting. Your nervous system is incredibly capable of change. And look at how motivated you already are. You came here. You want to help yourself. Let's figure out how much we can do together. Yeah. Another risk, I think, for people who do manual treatment is the idea that you're going to chase every single one of those pains and fix each one of them. I mean, how many of us have done that? It's incredibly addictive because you are the only person who can help me. Who's heard that one? Right? And how do you want to respond to it? Oh, I'm so awesome, right? Run away or I'm so awesome. It's one or the other, right? So what if you say, I'm so awesome? What if you say, well, I'm glad you're here. And I mean, that's good. I'm glad you're here. But what if you feed into that idea that you're the only one that can help them? What does the patient get in their mind then?
I can't help myself.
I can't help myself.
There are no other options.
There are no other options, right? And that external locus of control, then when it doesn't work with you, they have to go find somebody else who's the only person that can help them. So what's a more appropriate answer for you're the only person who can help me?
I like to use the term facilitator.
Okay? You like to use the term facilitator. Say more.
Well, that I'm just facilitating them in the journey that they're having with pain, whether it's that they're as big a part of it as I am.
That they're a bigger part of it as I am. That's, I think, even more important than you're a facilitator. What can we say more that provides even more of a sense of an internal locus of control? Feeding on that, yeah.
I like to empower them and say that as long as we both have the same intention, I said I am just the instrument.
Okay, I'm just the instrument. I like to empower them.
Professional space maker. I use that one a lot.
A professional space maker.
Yeah.
Okay.
Yeah, I just like to refocus back to how short of a period of time maybe we've been working for 15 minutes and already you're feeling better, and then start to talk about how that could possibly happen as a result of changes that I've made. It's interesting what your mind or your brain or your body has been able to do, and then I start to say, with some curiosity, do you think you could create this kind of feeling in another context, like at home?
That was great. So I'm going to repeat that. So what she says is that she likes to raise the awareness that just in 15 minutes a person already feels better, and emphasize that that could not possibly be a result of the things that she did, but rather the things that happened inside that person. Let's talk about some ways that person could create some of that feeling on their own. That's fantastic. And I think what that can be, and this is where I think that the videos can help, and also we have pain education classes. I guess I didn't get that up, but we have pain education classes at Providence, and people can come to them from everywhere at providence.org/classes, pain education. A little bit of extra pain education that helps people understand how powerful changing the autonomic nervous system is in affecting pain is a booster, because if they still believe that the pain comes from the body, they're only going to believe they can do just so much because basically they're damaged. And we need to help people realize that basically they are incredibly resilient and capable of change. That's the message, and that's fantastic. So and then I'm going to stop in just a moment. What about what is a way that you could respond in a more neuroplastic way to I hurt everywhere? That might help instill a little bit of pain education and a little bit of a sense of internal locus of control.
Well, what things do you do increases the pain as far as you notice it when you're at work, when stress at work's high, or when you're in traffic?
So the comment was, well, when do you feel the pain more, for example, if you're in stress at work or when you're in traffic? And then how would you go further with that if they say, well, it's definitely worse, it's better when I'm on vacation, right? People say that all the time.
And then I would say, as I do daily now,
Yeah.
how do you find yourself to be able to disconnect yourself from stressors in your life? How do you relax? How do you find time for yourself?
So how do you relax, and how are you able to deconnect from stressors in your life? And I would say there's some backstory there that you need to connect people to, which is helping people really get how stress and pain are closely linked. That stress and pain are both part of the emergency response system, right? And so when a person experiences more stress when their fight or flight system is turned up, then their system is going to sense threat more, and they're going to feel pain more. That's how we work. That's how we're wired. Pain is designed to get our attention. And so those two mechanisms go together. And when you can quiet the fight or flight system through relaxation work, you can quiet your stress. Yeah?
I don't know if I actually have
Quiet your pain, that's what I meant.
a dialogue, but it's more of a visceral. So getting them, or encouraging them to have a sense of control, which if they feel like they're out of control, it heightens a sense of awareness. So I always help to cue their breath. So when they are tapping into their breath, it's something that they can control. So once they have that little ounce of sense of control, then their pain, perception of pain decreases.
Great. So tapping into awareness of breath and use of breath helps people feel that they can do some modulating of their autonomic nervous system and then feel that they can change their pain. And that's a great teaching tool. So then helping people become aware. So you just did that thing that we talked about quieting the fight or flight system. You just did that in a very short period of time. And the more you do that, the more those pathways in the brain for a sense of safety and resilience become stronger, and the pathways that have become really wired well for producing a pain experience, those become weaker. You just started that. That's great.
If the breath is a resource, sometimes paying attention to the breath is not a resource.
Sometimes paying attention to the breath is not a resource for people. Say more about that.
It can be a traumatic process for some people to pay attention to their breath because they have had a previous trauma with paying attention to their breath.
Okay, so if people had a previous trauma with paying attention to their breath. Okay, there's maybe some other ways to get at physiological quieting then. Like, yeah, I mean, when you look at mindfulness work, people will be able to connect more easily to different things. So there's lots of great comments, and am I okay to keep going, or do we want to stop and go to the panel?
Bring other people up.
Yeah.